Now, I said before about the distinction between lymphomas and leukemias. And at the end of the day, in many circumstances, lymphoma and leukemia is part of a spectrum. So they're not necessarily completely separate diseases. So lymphomas are obviously tumours of the lymphatic system that predominantly involve the lymph glands, whereas leukemias refer to involvement of the bone marrow, but more specifically the blood. So when something is regarded to be leukemic, it means that there's actually circulating cells from that disease in the blood. Now, we know that lymphomas can become leukemic. So we often, in patients with very advanced forms of diseases, we will often see lymphoma cells that have jumped out from the bone marrow and are circulating around in the blood. So really they're behaving like a type of leukemia. And for example, there's actually some scenarios where the same disease has two different names. So chronic lymphocytic leukemia, or CLL, can sometimes not involve the bone marrow in the blood and just involves the lymph nodes. And then it is called small lymphocytic lymphoma, or SLL. So it's exactly the same disease, but with a completely different spectrum when it turns up. So I said before, the other important thing about diagnosis is it can help work out the treatment. Now, Hodgkin's and non-Hodgkin's are treated in general completely differently. So the standard of care is probably ABVD, although, as you mentioned, BCOP is another alternative treatment that we can use for people where their disease is clearly behaving badly. More intensive than ABVD, more side effects that go along with it. Whereas for most forms of non-Hodgkin's based treatment, alkylator type drugs, so they're things like cyclophosphamide, chlorambucil are the mainstay of those particular treatments. So CVP and CHOP and those type of protocols. If you have a B-cell lymphoma, you will almost always get rituximab or MabThera included as part of your treatment, simply because B cells are the ones that express the protein that MabThera binds to. That protein, CD20, is not on T cells, so it's pointless giving MabThera in that class of disease. And that's another reason probably why T-cell lymphomas don't do as well as B-cell lymphomas, is that we don't have MabThera there to improve the outcomes. So there's really two or three of the main subsets of lymphoma or leukemia where maintenance MabThera has a very established role. I think it's managed to go beyond that though, so I think pretty much a lot of doctors are using maintenance MabThera in anybody with a B-cell lymphoma. The way of doing MabThera is where you have it by itself for 4 weeks in a row, which is a very intensive way of actually shrinking tumours down. And the really slow-growing lymphomas, it will often respond very well to that and it stays in remission for a long time. You'd never consider doing that for one of the more aggressive ones. MabThera by itself for an aggressive lymphoma might shrink it down very briefly, but it would very quickly start growing again. So for the marginal zone lymphomas, this standard sort of CHOP or CVP type treatment often doesn't work very well. So these are disorders where you sometimes need to use drugs like fludarabine, if anybody in the room's heard of those. And the other thing is that I mentioned before about involvement of the spleen. One of the subtypes of marginal zone lymphoma, which is the splenic type, the single best treatment is to remove the patient's spleen. And that can be curative, so because you're removing the only source of lymphoma. Now, we rarely do surgery in lymphomas. There's very little point other than to get a diagnosis. But this is one of the classical examples where the first type of treatment that has the best potential is actually surgery. I've mentioned about Burkitt's lymphomas. So because they behave very aggressively, we actually use leukemia-style protocols, so really intensive protocols for that type of disease. Now, for the really slow-growing lymphomas, you may not need any treatment. But if you've got one single site of disease, if you've got, for example, follicular lymphoma, then radiation treatment to that site of disease may actually cure that lymphoma. And that's one of the rare circumstances where follicular lymphoma can be cured very early on in the disease course, because it does tend to be a disease that relapses over a long period of time. Most of the time when people turn up, there are multiple spots involved, but there are rare circumstances where people will turn up with a low-grade lymphoma. You can only find one site on a CT or a PET scan, the bone marrow is clear, and in that circumstance, some radiation treatment is a very appropriate treatment, and it actually does have the potential for curing the disease. It's again, because the lymphatic system is a continuous circuit like the blood thing, the lymphoma cells can very easily percolate their way through the lymphatic channels and make it to another lymph node group. What we don't understand very easily though is that you can get circumstances like somebody has a lymph node up here and the only other lymph node is a lymph node in their groin. And if it has travelled through the lymphatic system, you would have to make a presumption that it's travelled through multiple lymph node groups to get to there. So it's one of those things that we don't understand very well. If you think about lymphoid cells, though, a lot of lymphoid cells spend time outside the lymph glands. They travel into the blood, they travel into the organs to help fight infections. So they're presumably quite mobile, and that's part of their role, is to be able to get out of the lymph glands and do things. So the lymphoma cells probably retain that ability to mobilise themselves. Average life expectancy for somebody with a follicular lymphoma is probably in the order of about 13 to 15 years. And that's, again, having multiple treatments during that time. So, you know, you can have treatment, stay in remission for 5 or 6 years, and then it comes back, get a little bit more treatment, comes back again. So with the more aggressive lymphomas, generally if you've been in remission for 5 years, we start to think about that cure word, even though it's one that we don't often mention because of superstition. But follicular lymphomas are a disorder where you never realistically can say that. So if in particular you have a really long period of time in remission, then that would be an argument against doing a stem cell transplant as part of the next treatment. So I mentioned before about the genetic structure of the lymphoma cells. So all of the cells in our body are made up by chromosomes. Chromosomes contain genes. Genes are the building blocks of everything inside us. So genes make proteins. So when a gene gets switched on, it makes a protein. A lot of the research that's happening at the moment is really trying to tease out the genes that give lymphomas and leukemias a survival advantage. It either means that they don't die properly or they grow faster than normal healthy cells. So all of us have 23 pairs of chromosomes inside our cells. So we get one pair from our mum, one pair from our dad. That's 22 normal chromosomes and then the sex chromosome. So boys will have an X and a Y chromosome. Girls will have 2 X chromosomes. Now, this is an example of what, and this is a tricky one, this is an example of what the genetic structure or karyotype of somebody with Burkitt's lymphoma. This is what the cells look like. So basically in Burkitt's lymphoma, a bit of chromosome 8 gets broken off, and I know it's really hard to see here, and I'll show you an example soon of something that's a bit easier to see. A bit of chromosome 8 gets broken off and gets attached onto chromosome 14. That's really bad because the gene where it gets broken off on chromosome 8 is what's called an oncogene. So it's a gene that can do bad things. Where it gets attached onto chromosome 14 is the part of chromosome 14 that helps make antibodies. Antibodies are things inside us that are responsible for helping fighting the immune system. So it's a gene that's switched on pretty much all of the time because we're always making new antibodies to make up for things. So what actually happens is when the bit of chromosome 8 gets stuck onto the chromosome 14, it becomes an active gene. The 14 means that the oncogene, or the bad gene, is permanently switched on. And that then drives the actual Burkitt's lymphoma to occur. So this is and the gene on chromosome 8 is called the MYC gene. The other way that we can look at these chromosomes is through a thing called FISH. So FISH is a colourful technique. So basically this is using 2 probes, one that binds to chromosome 14, which is a green probe, one that binds to chromosome 8, which is a red probe. So before, where I was talking about this chromosome abnormality, you get a bit of 8 and a bit of 14 wedged together. And this is the abnormal 8-14 translocation. And you can see where it's wedged together, it forms a yellow because of the combination of the green and red signal. So this is another way that the pathologist can find the presence of this 8-14 translocation. And anybody with this translocation is regarded at very high risk of disease recurrence if we don't treat them with aggressive types of treatment. This is the type that we see most commonly in follicular lymphoma. It's this thing called the 14-18 translocation. So the chromosome 14 is the same thing that we were talking about before. It was that part of the immune system where part of the genetic system where antibodies are produced. But in this case, it's a bit of chromosome 18. The bottom there has been broken off and attached onto the bottom of this chromosome 14. So you can see the difference in length between these two things. The bit of chromosome 18 is the BCL2 gene, and BCL2 is thought to play a very integral role in why follicular lymphoma develops. BCL2 is a gene that is meant to be turned off to enable cells to die. So because of this translocation, BCL2 is constantly switched on. And so lymphoma cells don't die, they become immortal in effect. So that's one of the reasons this type of lymphoma can do what it does. There's a couple of other abnormalities here. So this, for example, that's a normal chromosome 6. This chromosome 6 has lost a bit of the long arm, and there's 3 chromosome 8s. So you often see additional abnormalities when the cytogeneticist looks down the microscope. The moment you detect this 14-18 translocation, the pathologist becomes very confident this is a type of follicular lymphoma. And this is what the fish looks like again. So red is normal 18, the green is normal 14, and again, because of the 14-18 translocation, you then end up with this bit where it's yellow. The final one to mention is a relatively rare disorder called mantle cell lymphoma. Mantle cell lymphoma has a problem with the cyclin D1 gene on chromosome 11. It gets broken off and attached on, sorry, this is chromosome 11 here. It gets broken off and attached onto chromosome 14. Same spot as before, so the antibody producing gene. So that's the common factor. You're getting these bad genes being translocated onto a gene which is very active, and it switches that gene on permanently. So the 11-14 translocation, again, is the hallmark of mantle cell lymphoma. And again, this is just a fish. So green, normal 14, red, normal 11, and that's an 11-14 translocation showing up. So in addition to making those slides where we saw the main thing the pathologist is looking at, they actually send some of the sample off to one of the cytogeneticists who then looks down a special microscope at these things here. And that same cytogeneticist also does this, looks down a fluorescent microscope at these things. For these ones, they'll map out 20 cells. So they'll look at 20 individual lymphoma cells and see whether they're all the same. You might find that, say, 17 out of the 20 lymphoma cells have these abnormalities. More made for diagnostic purposes. It can be useful later on down the track, though, to do follow-up, like if you had disease in the bone marrow. You do a bone marrow, you can send the samples back along to the cytogenetic person, get them to look down the microscope and see if they can find these abnormalities again. Normal healthy people can have minor changes in their genetic structure. For example, some people will have an extra, as we get older, will lose the Y chromosome often. It's got nothing to do with loss of testosterone or anything like that. It's actually just one of those things that can happen as part of that ageing process. So you can find minor abnormalities. If anybody knows Down syndrome, for example, the classical thing that you see there is where you get an extra chromosome 21. So that's how they make a diagnosis of Down syndrome. Similar sort of concept to what we're doing here. These things, they actually look at 500 cells. And again, there's very few scientists who are trained in doing cytogenetics in fish. And probably each of the main labs around the state, so Pathology Queensland, which is the public system, QML, Sullivan Nicolaides, probably only have one person each. So if that person goes off sick for the day, it just causes enormous problems. It's such a highly trained skill that they're doing. These things are not cheap either. Like a standard fish probe is about $500 to $1,000. And most of them aren't covered by Medicare. So if you've had tests done and you get sort of an extra bill, if it's been done through the private sector, that, at least in part, might be one of the reasons why. Now, I'm just going to mention this in brief. It's a new entity. We're still learning about this particular thing. We've known about lymphomas before that weren't easily classifiable. In particular, some of the things called Burkitt's-like lymphomas. So it's not Burkitt's lymphoma, and it doesn't appear to be quite able to fit into diffuse large cell. And we're often making distinctions between those two disorders because diffuse large cell lymphoma probably just needs CHOP-MAB therapy most of the time. If you really think something's a Burkitt's, you need to treat that with high-grade leukemia-style protocols. If you give somebody with Burkitt's CHOP, their disease will initially respond, but they will very quickly start growing through cycle 3 or cycle 4, and they will often be untreatable then. So getting the distinction correct at the start is really important. Now, we're talking about these double-hit lymphomas now because we're starting to find a range of lymphomas where when we look down the microscope, they look like diffuse large cell lymphoma, so they look like the most common type of lymphoma that we see. But when the cytogeneticist looks down their microscope, they find the classical Burkitt's translocation, but also the one that we see in follicular lymphoma. So you've got something that looks like the standard aggressive lymphoma, but has the cytogenetic abnormalities of the most common low-grade lymphoma and the most common highly aggressive lymphoma. So what we know about this disease so far is that people who are treated along the lines with standard treatment don't do very well. So at the moment, if you walk through the door with this type of disease, you will be treated with aggressive lymphomas. The difficult thing is, because it's a new entity, we actually have not yet had sufficient time to know whether these more intensive treatments will lead to a better outcome. Fingers crossed, hopefully they do, but only time will tell. There's a new concept now also called a triple hit lymphoma, so where in fact you get a third abnormality on top of this. So again, it's only been established for about the last 12 to 18 months. When we go along to meetings about lymphomas, a lot of the discussion is sort of about new evidence that's coming out. So as I say, it's probably something that many of you in this room will hear about more in the future. And again, hopefully when we do, we start to find out that it's a disease that, with appropriately aggressive treatment, can have a very good outcome. We see about 45 to 50 new people with lymphoma through the Royal Brisbane each year. Probably about 1 in 10 will now have this concept of a double hit lymphoma. On the whole, most people who turn up with a double hit lymphomas, it's probably apparent that it's behaving badly anyway, because it's often advanced stage. Then they're feeling really sick. Their blood test numbers are right off. So there's probably been other clues that it was behaving badly anyway. So once we've got a diagnosis, the next step is the staging. And again, sort of the same information that I said before, it does help work out what eventually we need to do. So staging determines prognosis. It can often determine the type of treatment. And more importantly, once we know where the lymphoma is, later on down the track when you've had some treatment, you can then work out if it's still there or hopefully it's all gone. So not only is it important to know where it was when it starts, but it becomes crucial to work out how well the treatment's actually worked.